I'm Valerie Page. I'm a consultant in intensive care at Watford General Hospital. Really concerned about ICU delirium. It's a really common problem in our patients. The patients in our study had over a 70% chance of getting delirium. So we've been searching for a drug to treat intensive care delirium, and we were looking initially at haloperidol. That does not manage the delirium. So we've gone on to Simvastatin. It has anti-inflammatory properties, and the hypothesis is that because delirium pathophysiology is almost certainly associated with neuroinflammation, that if you can reduce the inflammation, that will decrease the delirium and improve outcomes. It was a phase 2 trial. It was a randomized double-blind placebo trial. It was powered for delirium coma-free days. So basically to increase the amount of time the patient spent with normal brain function. We gave half the patients Simvastatin and half placebo, and then we saw how long they were delirious for. And the patients who had placebo had the same number of days in delirium as the patients with Simvastatin. So ultimately we demonstrated that Simvastatin does not help to reduce delirium in intensive care patients. My goal now is to reduce the factors that make patients more likely to get delirium. So what is a strong factor for patients getting delirium is the use of sedative drugs. The more sedative drugs the patients get, the more likely they have delirium. And those studies where they've managed to reduce sedation have managed to reduce delirium as well. So what I would like to do is to get a means by which to enable nurses to maintain patients safe, awake and comfortable with the current drugs that are in standard use, rather than keeping them over-sedated, which is a big problem in intensive care at the moment. So that's a sort of non-pharmacological intervention, because I don't believe that at the moment there's a pharmacological intervention that's going to help in delirium. But there are lots of researchers who think there are, and I wish them the best luck in the world. People often think with trials that don't show a result, it's just that we didn't do enough patients, or we didn't have the right outcome, or and when people are committed to an idea that a drug, how can it not work? It's got all these anti-inflammatory properties, innate and acquired. The fact is that I think we've demonstrated it doesn't work, and there was no signal. So what I would like to say was, I think we should believe the results and not worry about investigating statins in delirium in critical illness. What I would be excited about is convincing the clinicians who do not believe, who are non-believers, that delirium matters. It's important to our patients. If we've got to look for it, we've got to find the delirium. If you don't screen for it, you won't find it. If you don't know it's there, you won't want to manage it. And I think we need to, if there's signs of delirium, we need to look for the cause intensively and aggressively and manage it.